Good morning and thank you very much for this opportunity. I'm going to talk on the subject of patient safety, which is extremely important. Not only the entire hospital, but each and every healthcare worker must be familiar with this term in order to improve the patient outcome. Unfortunately, what I have observed that many of the doctors are not even familiar with this term and they do not understand the meaning of this term. So if at the end of this lecture I am able to sensitize you guys about what is the meaning of patient safety, I would consider that my work is done. Now the present day patient care revolves around highly engineered equipment. It has changed. The technology has invaded the medical field. The medications have improved. In addition, there is a human interaction. Let me elaborate it further with the help of this picture, which is a picture from our transplant operating room. So you see the stack of syringe pumps here. That's the hemodynamic monitor. That's the monitor screen of the ventilator. This is the near infrared spectroscope. This is the BIS monitor. That's the continuous cardiac output monitor. You have a infuser, rapid infuser here, and the new gadget nowadays we are using is transesophageal echo. In addition, you have the TEG, ABG, many others. There are so many other parameters which are being used by the team of doctors. So a team of 3 to 4 anesthetists here, about 4 to 5 surgeons, 4 to 5 nurses. So number of people are on a single patient. And if you add to this the post-operative period, about 6 to 7 days admission, then a team of about 40 to 50 individuals would be working on a single patient. This is an animation of a hybrid cardiac operating theater which has been recently introduced. You can see the robotic station here, then you have the fluoroscopy, and you have the heart-lung machine, and the patient would be somewhere here, and a team of cardiologists can perform an angioplasty stenting, and the cardiac surgeons can perform the bypass surgery if required. So again, you can see that a number of people would be working on a single individual patient. Fortunately, the technology that has invaded has got several safety mechanisms inherent in most modern equipment, and they would fail with safety. So if you have a ventilator which has a oxygen supply being cut off, it will continue to work or ventilate the patient on air and give you an alarm. So although the ventilators or the machines fail safely, there is always a human factor that is involved. Always remember that the machines are for us, we are not for the machines, and the human factors are the ones which lead to some mishaps or accidents breaching the safety mechanism. Let me further illustrate this with the help of this cartoon. Here is a patient, and here is a list of several interventions, medicines and other things that we perform on the patient, and here would be a doctor or a team of doctors who would take help of these and interact with the patient. In addition, you have nursing staff which would be interacting with the doctors, and the paramedics which would also interact with the doctors. In addition, they may also interact with the patient itself. So this is a bird's eye view of what goes on. There are several other things that are going behind the scene which can create issues and problems related to the patient management, leading to major mishaps. So as you know, errors are an inevitable part of medical practice, and because doctors are humans and humans make errors, we can excuse ourselves from making these mistakes. Now this argument is not correct. Just imagine that if you were supposed to tell the patient that, sorry, I injected potassium chloride instead of soda bicarb, I am very sorry about it. Or an anesthetist goes and tells the patient that I am very sorry that I intubated the esophagus instead of the trachea and didn't realize it until it was too late. So these kind of arguments or sorry or apologies are not going to work. Hence, we have to work very hard to minimize these errors as much as possible. So let me define what is patient safety. There is one definition which says actions undertaken by individuals and organizations to protect healthcare recipients from being harmed by the effects of healthcare services. Now, what are the effects of healthcare services? This is a bit confusing. So if I catheterize a Foley catheter into the patient and he develops urethritis, that is a complication. It is not a safety issue. But if I catheterize without following these aseptic norms, that is a safety issue. Or if I pull out a catheter without deflating the balloon. This has happened. These are not stories that I am creating. All these things have happened in my practice. So a patient had a catheter inside. The catheter was withdrawn without deflating the balloon, and the patient was on anticoagulants or antiplatelet agents. So he had massive bleeding in the urethral bleedings. So this is a difference between a complication and a safety issue. There is another more simpler definition which says that freedom from accidental or preventable harm produced by medical care. So preventable harm is the key word. So if the harm is preventable, that is a safety issue. If it is not related, if it is not preventable and it is not related to the primary disease, then it is a complication. It is not a safety issue. Now, what is the relevance to the healthcare system? Why do we want to understand the issues related to patient safety? As you know, there are a significant number of patients are harmed from healthcare services, leading to permanent injury, increased length of stay, or even death. So this is the reason, and if you search the literature, there is not much literature available on this. However, I have taken out some of it. So this paper, published in 1995, a long time ago, has concluded that serious adverse drug events were often preventable. Remember that they are often preventable, and medications harmed patients at an overall rate of 6.5 per 100 admissions. That's a fairly high number. Remember, most resulted from errors at ordering stage. So those of you who believe that it is the administration stage which is relevant for producing a complication, remember that most errors resulted at the ordering stage. So everyone is involved in this medical errors if they happen. So this is a WHO statement which shows that, I will read it out. Statement: the nurse gave the wrong drug. Why? Because she misheard the name of the drug ordered by the doctor. Why? Because the doctor was tired and it was in the middle of the night, and the nurse did not want to ask him to repeat the name. Why? Because she knew that he was known to have a temper and would shout at her. Why? Because he was very tired and had been operating for last 16 hours. Why? Now this can go on and on. The gist of the matter is that a terminal event of injecting a wrong medicine revolves around series of previous events which will culminate into the administration of a wrong medicine. So in Australia, this paper has shown that as many as 18,000 unnecessary deaths and more than 5,000 disabled patients in a period of 1 year. And in the USA, this paper has highlighted that about 44,000 and as many as 98,000 unnecessary deaths each year and 1 million excess injuries. So these reports are a little older. Let's look at some of the newer reports, again from the USA. So between 200 to 400,000 patients each year who go to hospital for care suffer some type of preventable harm that contributes to their death. And it is the third leading cause of death in the USA after heart disease and lung cancer and the cancer. Remember that we are talking of preventable harm. These all deaths are preventable. In one of the lectures here in this auditorium only, I heard that there are about 25,000 patients who require liver transplant every year, and we are able to perform only 5,000, denying treatment to 20,000 patients who die. Now look at the 20,000 figure and these 440,000 patients which can be prevented without causing any harm to the patient and providing absolutely normal life. Lancet published an editorial recently which described that countless patients are put at risk by unsage. Unsage means unsafe. I had to look up the dictionary to understand what is the meaning of unsage. And although I am a believer that you should not use floral language in the scientific literature, Lancet often uses it, and I have to refer to the dictionary to understand it. So countless patients are put at risk by unsafe care that ends up, suffering from some complication by the very system that was supposed to help them get better. And in addition, it says that most of but no health system has so far successfully addressed the patient safety. So these are very important publications that I am citing, and WHO has given that this data for that low and middle income countries have about 134 million adverse events which are directly attributable to the unsafe care, and there are 2.6 million unnecessary deaths. So this is the reason why you need to understand why you should, this patient safety should be an important consideration. You may not be knowing, I also did not know it till very recently, that there is a day called as World Patient Safety Day on September 17, 2019, and this year the theme was the safe maternal and newborn care. Now there are various types of safety: medical safety, surgical safety, electrical safety, laboratory safety, sanitation. You think of anything and it involves a safety issue. It will not be possible to discuss all of them, but I'll discuss some of them to just highlight what safety issues are. Let's look at the medication errors. And this publication is by Ravi Mahajan. I would like to say a few things about Ravi Mahajan. He is from Delhi and he is presently in Nottingham, and he happens to be the past chief editor of British Journal of Anesthesia, and currently he is the president of the Royal College of Anesthetists. So a big rise for an Indian in the UK, and to him the safety issues is a very close subject to him, and he writes that during anesthesia and intensive care are among the top 10 causes of overall mortality. And in ICU, the incidence of adverse drug events is 130 errors per 1,000 patient days, and these figures are likely to be an underestimation because people do not report the incidents or mishaps. Now, medical errors could be wrong medicine, wrong dose, wrong site, omission error, and wrong time of error. So in an anesthetic conference, if I ask the audience as to how many of you have committed these errors, almost everyone raises the hand. But if I raise the same question in a cardiological meeting, only few hands are raised. And if I raise this question in the cardiac surgical audience, no hands are raised, because most of them believe that they never administer the medicine, so they cannot be a part of medical error. But as I mentioned, that everyone is a part of the terminal event that takes place by way of medical error, and you may be responsible for that. So wrong medicine is a result of look-alike and sound-alike medicines. So let me give you some examples. An anesthetist ordered esmolol and he was provided with esmeron. Esmeron is a muscle relaxant. And in my own experience, when I asked the technician to provide me with isoprenaline, he was going to provide me isoflurane. So now this kind of mishaps are known to happen because of, the drugs, they are sound alike. And these are the look-alike medicines, and you may be aware of this. So who is responsible if the medical errors takes place in such situations? The administration is also responsible. If they have purchased these lots of medicine and it has been brought to their notice that they look alike and they could lead to some accidents, still the purchase is being continued, then there is some responsibility by the administration as well. Now, if I administer midazolam instead of atropine, I do not produce much problem. It doesn't concern a little bit of sedation, the patient will sleep. But if I administer pancuronium instead of atropine, it could be a serious disaster, especially in a ward or in an ICU where anesthetist is not available all the time. Or if I administer epinephrine instead of lignocaine, that could also create an havoc. Now, all these are not my imagination. All these things have happened. Believe me that they have happened in front of me at one place or the other. And many of us are inclined to believe that this does not happen with me. मेरे unit में नहीं होता, वो दूसरों के unit में होता है. That's what the tendency is. So we have to, rise above this. It is like saying that मैं जब red light jump करता हूँ तो बड़ा carefully jump करता हूँ, इसलिए मेरा accident नहीं होता. That kind of philosophy does not work, and each one of us has to be convinced that someday it is going to strike them. Likewise, if I administer KCL instead of soda bicarb, I have seen patient dying due to this reason. The other thing is you can, administer a wrong dose due to no label, wrong interpretation of the label, or assumptions that ये double strength होगा, single strength होगा. No, I hear these terms. Epinephrine double strength जा रहा है, norepinephrine single strength जा रहा है. There are no labels, and you have to rely on an individual to give you an information which may or may not be correct. So even the labels may not rescue all throughout, because there could be some look-alike labels, as I have shown you here. Wrong site injections are also there. Among these, the intra-arterial injection is fairly common and can happen because we cannulate the arteries very frequently nowadays, and if they are not labeled properly and if the nursing staff is not educated properly, then there could be injection of some medicine in the arterial line. Now, there are very few reports, as I mentioned, because most people do not like to publish. Then I found 2 of them which relate only to cardiac anesthesia practice: administration of protamine rather than heparin. There is another report, again, improper administration of protamine. So instead of giving heparin, the authors administered protamine. And I believe that these papers have been published because the outcome was good. If the outcome was not good, these papers would not have appeared and we would not have known that these things happen. So in an ICU, administration of a single dose of medication may require between 80 and 200 individual steps on prescription, transcription, preparation, dispensing and administration. So it is not only the person who administers the medicine is responsible for the fault that might result into a problem in a given patient. So the consequences of medication errors are, fortunately, many will escape harm and some will sustain significant injury. There could be long-term harm and even death. Now here I would like to show you what is meant by the Swiss cheese model. You know that there are series of holes in the Swiss cheese, and if you cut the cheese you can see these holes. Because the holes do not match with each other, you cannot see through this cheese. But when they match together, you will be able to see through this. So here is an example of incorrect adverse event due to wrong site surgery. And these are the various errors that have taken place at various levels of safety. And I like to describe this as levels of safety. In a given hospital, there are various layers of safeties. You have a technical staff, you have a junior resident, you have a senior resident, you have a junior faculty, senior faculty, nursing staff. So each layer commits some error or the other all the time. Every day this is happening. The only fortunate thing is that they are not happening at the same time. If they happen at the same time, उसी दिन जो है वो थका हुआ था, उसी दिन एक जो है थोड़ा careless resident duty पे था, उसी दिन जो है label नहीं लगा हुआ था, and it culminates into a major mishap. So that's what the Swiss cheese model is. Let me talk about some surgical errors. So the universal protocol for preventing wrong site, wrong procedure, and wrong person injury. This is, as you know, that a limb that was supposed to have not been operated is operated upon, or a craniotomy performed on a normal site. So you need to conduct a pre-procedure verification process, mark the procedure site, and a timeout is performed before the procedure. Now this is a WHO checklist which has been given before induction of anesthesia, before skin incision, and before patient leaves the operating room. And this footnote is very important. This checklist is not intended to be comprehensive. Additions and modifications to fit the local practice are encouraged. So this is not the end result. You can modify it to the way you like to suit the local scenario. Now a few examples of Indian scenario. This is 6 deaths due to oxygen failure in 2012, and I inquired into this incident, and I know that everyone involved, from the technical staff to the senior most doctor in that hospital, was liable and responsible. Not only that, even the administrators in the Sachivalaya were also responsible. So it was a mistake committed at every level, which culminated on this particular fateful day, leading to 6 deaths. Gorakhpur tragedy of 60 children dying, and this baby dies due to wrong antibiotic shot. So a concentration, various concentration, double strength, single strength, that was left in the refrigerator. I won't name the hospital here, but a higher concentration antibiotic was administered, and many children died. Some of them died, some went on ventilator. So we have to be very careful if you want to avoid building such memorials in future. This is a memorial built in memory of the Amri Hospital fire mishap that took place in Calcutta. So what should be done? Having understood as to what the problem is, what should be done? For that, you have to understand this Tenerife Air Disaster, which is the worst aviation disaster have ever taken place. 2 Boeing 747 passenger aircrafts collided, and 583 people died. The KLM flight took off while the Pan Am aircraft was still on the runway, and poor visibility due to fog was one of the reasons, and there was a communication gap between the pilots and the ATC. So aviation industry, we have to learn a lot from aviation industry, who formulated various practices and protocols. They resorted to use of standardized phrases. So unless the ATC says these words, okay to take off, the pilot cannot take off. You cannot rely on, okay, you can go, ready to go off. Those kind of terms are not tolerable, and the pilot will not take off unless these particular terms are uttered by the ATC. The junior flight crew members were encouraged to challenge their captain, and captains were instructed to listen to their crew. Likewise, we have to follow some of these issues and take into healthcare industry, because health is also an industry nowadays. The traditional teaching, there is a significant emphasis on knowledge acquisition and skills. So we consider that medical science means knowledge and skills. And skills, what is the nature of the skills? Life-giving, life-saving, and life-rejuvenating. So we are dealing directly with the life. And Nowadays, as I mentioned, the MCI has introduced the Attitude, Ethics and Communication module in 2016 only to highlight these facts about the non-technical skills which we do not acquire or we are ignorant about. So the non-technical skills are defined as the cognitive, social and personal resource skills that complement technical skills, and they contribute to the safe and efficient task performance. They enhance the personal skills, and little attention had traditionally been paid to this part of our behavioral component. Let me give you some examples. So an anesthetist who is an expert in arterial cannulation, he is an expert, he can cannulate the artery by his left hand, but he uses this in a patient who is undergoing hernia repair where it is not required, and the patient suffers from arterial thrombosis and some complication, or he administers an epidural catheter who is on antiplatelet agents. So these are the issues which you need to take into account. Or a cardiac surgeon who is a skilled and crafty surgeon who can anastomose any coronary, but he anastomoses a wrong vessel, or he anastomoses the vessels on a patient who does not require it, who can easily be managed by medical treatment, such as an 80 years old man who doesn't do much of activity, has got a single vessel disease, can be very easily managed by medical management. So these are the various components of non-technical skills. These are the categories. I have never understood why this is the sequence that is followed. In my view, it should be situation awareness, decision making, task management and team working, and these are the various elements. There is no time to discuss all these issues, but I will only emphasize one thing, and that all these parameters rest on a single issue of communication. Unless there is good communication, you are liable to commit errors. And WHO emphasizes that safe health care starts with good communication. And these are some of the recommendations to minimize the drug error, information, communication, standardize and quality assurance, and all these things are there. And you need to have good stacking of your, just as you in a store you have good stacking of the material, you can also stack them in the medical store. Not only that, you should have these syringe pumps are stacked nicely, but they do not have labels. So if you have nice labels here which can be seen from a distance, and I would go a step further by saying that you have a place designated for each medicine. So this is for number 1 is for norepinephrine, this is for terlipressin, this is for vasopressin. So I know which syringe pump is going on, and there are less chances of committing mistakes. Now, nicely labeled syringes are also a good option, and also you can have, these are commercially available labels which can be used, although they do not prevent the complications or errors 100%. These are the 7 steps for patient safety that have been recommended or described. I would like to focus only on building a safety culture. So blame culture is not desirable. You should not blame the individual, because I have highlighted that it is not the individual who is responsible, it is the entire system or the entire unit that contributes to any errors that are committed. And punitive action sends strong signals. So we have to move to safety culture and have to understand that it is the systemic failure leads to any complication or mishap. Try to find out what happened rather than who did it. It is not important to know who has done it, but what has happened, and try to target and eliminate those reasons of the complication that have the issues that have led to this complication. And we need to stop pointing the finger. Now, incident reporting is one of the ways in which you can deal with this, and you have to learn from the previous mistakes. So incident reporting is, although important, can be compulsory or voluntary, but the incident reporting rate is very low in most countries. And some countries have resorted to anonymous reporting, so that you do not disclose the individual who is responsible for these mistakes. But believe me that once the incident is reported, you know where it has happened, and you may come to know very shortly as to who has done it. So stop finding out as to who is responsible, but try to find out what has happened. Now, experience. Is there a substitute for experience? So if Dr. Arora or Dr. Pamecha or Dr. Sareen says that in a patient who is not responding to any treatment, why not do this? And it works. Why does it work? Because there is no substitute to experience. Intuitions and the gut feelings, they work in a patient, in a person who is very experienced. And legitimate precautions. Some of us take legitimate precautions in order to take care of a particular complication or an anticipated problem. For example, if I am supposed to deal with a difficult intubation, I would like to prepare with a video laryngoscope, a fiberscope, a bougie, and all the gadgets that will help bail me out of the problem if I have. But some people believe that this is not required. मेरे experience में कभी हुआ ही नहीं, मैं intubation कभी fail हुआ ही नहीं. And that he may keep on saying. Likewise, other specialists may also argue like that. For such people, I only wish to say that there is only a very thin line between bravery and stupidity. Poor implementation of the recommendations is one of the reasons why these things keep on happening. Why do people not follow these guidelines or the processes that have been laid down? Because people argue that there is lack of class 1 evidence. Now I would like to say that if the level of evidence is poor, doesn't make a recommendation weak. Let us understand it for once for all, that even if the level of evidence is poor, the recommendation is not weak. There is lack of desire. People do not want to change. वही मेरे साथ होता ही नहीं है. Lack of professional and organizational leadership. So leadership has to be good in order to implement these issues. So for those of you who are always looking for the level 1 evidence, I would like to show this cartoon. Do you have any published randomized trial which says that if you jump out of the aircraft without the parachute, you are more likely to die? No. To give a more further example, is there any evidence randomized trial which has shown that oximetry monitoring in the operating theater leads to better patient outcome? There is none. Still, all of us religiously follow the oximetry measurements in all the patients. So, finally, I would like to give a case scenario which has happened here only without trying to blame anyone. There is a patient who is scheduled to undergo liver transplant. Donor is anesthetized, recipient is anesthetized. Laparotomy in the donor reveals a mass of 8.5 centimeter, ovarian mass query. Ultrasound reports were normal. Obstetrician was consulted, frozen section, benign mass was resected, and the surgery was performed. The ultimate outcome of the patient was good. However, it led to prolonged duration of anesthesia and surgery. It could have led to cancellation of the surgery, and relatives are taken by surprise, so they required a lot of counseling. Now, the issue here is, there was some error at this stage of doing ultrasound. Now, the immediate knee-jerk response to this event would be, let us do CT scan of all the patients so that we never face this. That's not correct. We need to find out what has happened at that particular time and take measures to ensure that it does not happen in future. Now, this video will demonstrate can you raise the volume, please?
They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
Why don't you show me how your inhaler works?
So a patient with asthma is complaining that she is not getting relief despite the best treatment that was offered to her, and the doctor tries to find out how is she using the inhaler, and this is how she shows she is using the inhaler. So there is a wide communication gap. The doctor has never explained to her how the communication is to be used. So I would like to end by saying that the Florence Nightingale has said this in 1683. It may seem a strange principle to enunciate as the very first requirement in the hospital that it should do sick no harm. As regards ILBS, I do not think I am capable of proposing any protocols as regards to safety issues, but I can give some guidelines. The first thing is that beware that the safety issues do exist, and that you have to accept that mistakes can happen and that they are preventable. One has to accept this. If you do not accept this, no protocols are going to work. Second thing is that move from blame culture to the safety culture. Checklists and protocols, prepare them and follow them religiously. Improve the communication. As I mentioned, that communication can be a huge gap, and may consider promoting incident reporting and set up an expert group to learn from it, and so that we can modify our protocols in future. Thank you very much for your kind attention.